Here we go. Thank you. Brent?
There we go. You can hear me now?
Yes.
Okay, excellent. All right. So give me 1 second. And you can see my slides.
Yes.
Perfect. So I'll talk about revascularization in a stable ischemic heart disease from an interventional standpoint. I don't have any disclosures except to say that I am an interventionalist. So if I have a bias, it's often towards doing something from an interventional point of view rather than not. Quick preamble, obviously prevention is primary for patients with atherosclerosis. Healthy lifestyle, diet, and a team-based approach to managing risk factors is central. That said, it's not effective in everyone, even those who are trying to optimize that aspect. So we're still left with patients with ischemic heart disease. I think you all understand what this is. It's atherosclerotic plaque buildup in the epicardials as well as the non-epicardial coronary vessels. And these patients can be symptomatic or asymptomatic. They can be stable. They can be unstable. And when we think about the umbrella term, again, stable coronary disease, which is the focus here in the bulk of our outpatient practice, we can think of it in terms of obstructive coronary disease, but there are also these new entities that we're seeing and describing more and more that are patients who appear to have ischemia with no obstructive epicardial coronary disease. And this syndrome exists both in the stable picture, but also in the acute coronary syndrome picture, where we see these patients who come in with all the signs and symptoms of an MI, but don't have disease on cath, at least the disease we can appreciate. And you'll learn more about that if you come to the NB Heart mini symposium in May. So why do we care so much about this? Obviously, it has a huge impact. It's a very common disease. About nearly 2.5 to 3 million Canadians are afflicted with ischemic heart disease. Men twice the rate of women, and men about a decade younger than women. And it's the second leading driver for morbidity and mortality within the country. At least 50% of the patients who have ischemic heart disease have angina as their primary symptom, and about half of the folks who come in with an ACS had preceding anginal symptoms. And about 1 patient with an MI, there's about 30 patients who have angina. So it's a very common presenting symptom and a very common malady. I think you all understand how to work up these patients. Generally speaking, we're starting with a patient who has either multiple risk factors or clear symptoms. When we think about chest pain, really, we're thinking about 3 aspects. We're thinking of chest discomfort, typically of a pressure, tightness, heaviness quality, provoked with some sort of stress and relieved with rest or nitro. This will lead to a workup looking for signs of ischemia. Typically, that workup involves some form of stress testing, which itself is guided often by the baseline ECG. Normal ECG will often lead to an exercise stress test, whereas ECGs with abnormalities may require stress imaging. And in some cases, depending on the patient's risk factor profile, they may go for coronary CT angiography, and some are referred for invasive angiography. So this is probably the most important slide because really this is the slide that's most supported by the evidence. The initial treatment for patients with ischemic heart disease that is stable is medical therapy, and we have great medical therapy now. Obviously, aspirin, statins have been cornerstone for a while. ACE inhibitors, ARBs, from an anti-anginal standpoint, beta blockers, and some newer agents that have come online in the last decade or so. And then modifying risk factors, both those that can be modified and acknowledging those that can't. And the fundamental goal with all of this is preventing MI and death and reducing symptoms and improving quality of life. These patients need to be reevaluated, medications up titrated. I mean, this is really the cornerstone for these patients. What about when we look at Revasc versus medical treatment? I mean, there's been many RCTs now, and there's been some recent meta-analyses of many of these RCTs. And generally speaking, they consistently demonstrate that routine revascularization, CABG or PCI, with medical therapy on board have not been associated with improved survival compared with medical therapy alone. I think that's a telling statement, because sometimes we see these patients, they've got clear severe epicardial disease. It's hard to ignore. And many of us, again, I would say are biased towards intervening, but, there's questionable survival benefit here. And how do we explain this? I mean, it's been shown that the anatomical CAD burden is a significant predictor of prognosis, but the severity of ischemia may not be. And thus, it may be that the driver for coronary events is predominantly the amount of arthroma rather than whether that arthroma is distributed in ways that elicit ischemia during testing or, in areas that we can appreciate in the epicardial first and second order branches. It may rather just be the overall burden. And medication works equally effectively along the entire coronary tree. So it's working even in those vessels we don't appreciate. Whereas when we revasc, really we're focused on those first and second order branches that we can see and target with our interventions, whether that's stenting or bypassing. But there are, obviously these patients sometimes do require revascularization. And, at the end of the day, we'd like to improve survival. That really would be the primary goal. Obviously, symptoms are important as well, but a hard endpoint like survival is really critical. And in the data certainly suggests that CABG may confer survival benefit. And I highlight may over medical treatment in patients with left main, 3-vessel, and ischemic cardiomyopathy. However, most of this data predates widespread contemporary medical therapy, statins, antiplatelets, beta blockers, newer anti-anginal agents. As well. So that's an important caveat there. These trials were done in an era that's not contemporary with how we practice now. And sadly for PCI, there's not really any robust clinical trial data demonstrating survival over medical treatment in these stable patients. But with some caveats, Revasc does improve symptoms and quality of life, but may not improve hard outpoints like survival in most trials. But RCTs tend to be unblinded, which is fine if you're looking at an endpoint like survival. It's hard to influence that in a biased manner. But with subjective endpoints, angina, quality of life, health status, an unblinded study may be problematic. Obviously, patients who've had bypass or have had stenting know they've had it done, and that comes with the possibility of an impact on their assessment of their symptoms in particular. Some data from DEFER and from FAME2 kind of illustrated this point of the subjective nature of symptoms and the possibility of a placebo effect. So patients in these trials who were told their FFR values were negative or that their stenosis wasn't significant, there was a 39% relative risk reduction in those patients in DEFER who reported chest pain and a 77% relative risk reduction in anginal symptoms reported by patients in those in FAME2. And this is without any changes to medical treatment or any attempt at Revasc. Just being told their lesion wasn't significant showed a marked reduction in their reported symptoms. And this makes you really wonder about the influence of placebo and the nature of unblinded Revasc trials when you're looking at symptom reporting, obviously not survival. So I'll go over some of the guideline updates from 2022 on Revasc, and I think JF will touch on some of this as well. So, I'll highlight the heart team first because we literally just finished our weekly heart team meeting. It's a central aspect of, I think, multidisciplinary cardiovascular practice in the contemporary era. It's a class 1 recommendation, and we routinely discuss complex cases involving the entire heart team. And I think that's an important point. So Revasc to improve symptoms, class 1, level of evidence A, and these are in patients who have refractory angina despite contemporary medical therapy, who have significant coronary disease that is treatable with Revasc. It is recommended to improve symptoms. Again, that's not survival. Obviously, if you don't have significant coronary disease, you shouldn't Revasc. So that's pretty self-evident. When it comes to survival, single or double vessel coronary disease that doesn't involve the proximal LAD, really there's no benefit here to Revasc to improve survival. And even stenosis within the prox LAD, in the stable patient with normal LV function, coronary Revasc may be useful. It's a 2B indication to improve survival, but it's again somewhat it's not clear cut. It's not class 1 level A evidence. And there's been changes in the guidelines recently with respect to multi-vessel coronary disease and the recommendations for Revasc in CABG. It's been downgraded to 2B. I think JF may touch on this more in these patients with normal LV function and 3-vessel disease. So that's quite a downgrade, and that was driven by some recent trial data from ischemia. LV dysfunction and multivessel disease remains a class 1 recommendation for CABG to improve survival in stable ischemic heart disease patients. PCI doesn't really have a class 1A recommendation in this regard. And left main disease, again, CABG is recommended. PCI, if it's amenable, is a 2A, but CABG is a level 1 recommendation, a class 1 recommendation. Skip that for now. So for complex disease, CABG is a class 1 over PCI for this type of patient. And obviously the same holds true for diabetic patients with notable coronary disease. CABG is preferred. That's not really changed much. And this is an important a group of patients because we do see these people come through the cath lab regularly. These are folks who are going for non-cardiac surgery. They've got risk factors, or they've had some symptoms. They maybe had a positive stress test, or there's just a concern that they have coronary disease, and they're sent our way for cath. It's important to note that those, without left main disease or non-complex CAD who are having a non-cardiac surgery, there's no role here for routine revascularization. So you may see us send some of these patients back saying, they do have disease, it's documented, they need aggressive medical treatment is paramount, but there is no role for Revasc. And I think that gives some people, especially the non-cardiac surgeons, pause when they're going to go ahead and do a hip or a knee or something like that. But that's where the data is. I'm not going to spend much time on this, but there are guidelines around optimizing PCI results. I'm just going to mention that coronary intervention from a percutaneous point of view, probably like the surgical domain, it's gotten more complex, and we've gotten more tools in the toolbox. A lot of what we do now is guided by intracoronary imaging, and there is data to say that we get better results from that, particularly with respect to stent thrombosis or target vessel revascularization or stent failure if we use image guiding. We don't use it in every case because there's a huge cost associated with it, but in certain cases it does get used, and we've all noted an increase in our use of this. Calcified lesions are prevalent in this older population. So often we have special tools for that as well, and ways of dealing with calcium. And these improve against stent expansion. This isn't a hard outcome driven management plan, but it's more about getting stents in and getting them optimized, again, to prevent need for revascularization. I think you all know about CTOs. I think Yarrow talked last week about CHIP, which isn't necessarily CTO specific, but does include CTOs as part of this complex high-risk interventional procedure. These are common in upwards of a quarter of patients. They're complex, they're higher risk. Sadly, the results from a hard endpoint standpoint are really not robust. And it's mostly driven by symptom improvement in these patients. And even that data, in fairness, is not ubiquitous or robust. In-stent restenosis is a common problem, less common than it would have been 10, 15 years ago, but still 5 to 10% of our patients will come back with in-stent restenosis. For those with aggressive in-stent restenosis, CABG is generally seen as a better option if they have coronary disease that's amenable. More stents aren't always a solution. I'm not going to talk about hemodynamic support. That kind of falls under the CHIP category. My final points are simply, stable ischemic heart disease is common, and it can be the kind of initial presentation, the initial symptomatology for those who end up presenting with ACS. Prevention is key, but obviously elusive for many, and not a panacea, even for those who make an earnest effort. Contemporary medical treatment, though, is first line, and really it's excellent, and it probably provides the most benefit in terms of survival for those that are up-titrated on optimal medical therapy. It really can't be understated. It's the least sexy of the things we can do, but it's the best for the patient. And hard outcomes are seen in patients with left main disease and complex 3 vessel, but for the rest, we're mostly talking about symptom improvement and not really survival improvement over medical treatment. And I think that's an important point. So I'll let JF let me stop my share.
Perfect. Thank you, Brent. Let me see if I can bring my slides. Hopefully you can see that. So thank you, Brent, for the a pretty thorough review of most of that, and I'm just going to sort of focus on a few highlights and a few things that I think are worth, and I'll thank you for 2 things that I took note when you first is mini symposium advertisement is very important. And two is your comments around epicardial disease is really what, from a stent point of view or from a surgical point of view, we fix. And it's something that's not always fully appreciated when we say that something cannot be done. It doesn't mean that they don't have coronary disease. Coronary disease is very common. It can be quite extensive, but clearly there are things that are not amenable, meaning that there is really no value in us fixing some of the epicardial vessels when the rest of the myocardial vessels are not seen, not visible, not, or diffusely diseased. So something very important. So there's a huge anatomic component to that, and I'll show you a slide of what I mean by that. So I really didn't want to be about, PCI versus CABG. They're really apples and oranges in my mind, in the sense that I'd like to think of them as complementary, where there are clearly areas where PCI is way better, and there are areas that probably surgery is favorable, but there's some gray areas which require conversation and then choosing the best things for patient. My next slide is just something that I was in the debate many years ago, and this is a slide my colleague debater put up. And it just to make you laugh a little bit, 2 days after CABG, you're still in the ICU. 2 days after PCI, you're probably on the beach somewhere. So there are major differences in what we provide. So the role of revascularization, in contemporary medicine is really an old story. And unfortunately, it's focused largely on PCI versus CABG. If I look at all these trials, whether it's the Barry trial, the Excel trial more recently, there are some which were Courage and Ischemia, which more focus a little bit on the medical side of things. But generally speaking, the role of revascularization and us trying to understand in our patient population is an old story. But that's evolved gradually over time. And it's largely based on this, and this comes again to my epicardial blood vessel. The way we tend to think about them is we think of three major territories, sort of the LAD territory. I'll try to put my laser pointer there. Whoops, let me see if I can get it. So you have the LAD territory, the right coronary, and the circumflex, and each of those would have small branches that you might graft. But these are the epicardial vessel. They're really not the nourishing vessel to the myocardium, and these are the things that we fixed. So the disease is obviously much more complex. And when we talk about three vessel disease in a simplistic manner, we mean in all three of those main territory. It doesn't mean three branches of the LAD, for example. And when we mean the left main, we mean that small, less than 1 inch long vessel between the aorta and the circumflex and LAD. And there can be huge variability on how long or at the anatomy of that. So as Brent pointed out, the old guidelines, and these are Canadian guidelines, still sort of fit this. There was generally many places where there were clear indications for us, depending on the severity of coronary blood vessel disease, in terms of class 1 and class 2A indication for many of these. So generally speaking, revascularization was chosen when we felt there was a prognostic lesion, meaning that we potentially would impact not only symptoms, but potentially people's lives. And that included proximal LAD disease being in there, three vessel coronary disease with extensive disease, and or left main. And ejection fraction is often considered in that. And generally speaking, also the more severe the disease, there tended to be a favored between CABG over PCI around complexity. But again, that data was something that we don't see very much anymore, is that syntax score. It certainly does not appear in the current guideline. But I just want to point out, this is an important change, as Brent pointed out, is the more recent guidelines have really sort of changed. As you can see here, both for in PCI and or CABG, there were class 1 indications in some of those categories, and these were downgraded to class 2B indication. It's subtle sort of language, and it's worth reading that language. And of note, the European guidelines did not do that. They stayed still where they were, while the Americans won, and it created quite a bit of kerfuffle, as you might imagine. So basically, in patient with stable ischemic heart disease, normal ejection fraction, three vessel disease, and anatomy suitable for CABG. CABG may be reasonable to improve survival, so it's maybe. And then on the PCI side, an anatomy suitable for the same thing for PCI, the usefulness of PCI to improve survival is uncertain. So they're both sort of vague sort of statement for both of these. And so has that impacted a lot of what we do? I think what it changed is really the need for us to reflect a little bit and again highlight the need for us to optimize our medical management. And this is the way now we tend to see, and it's a reasonable way of algorithm, when we see stable ischemic heart disease patients, we really focus on, do they have a lot of symptoms that we can improve, or do they have indications to improve their survival from an anatomy point of view? So those are the kinds of things that go in our mind. So in patients who have, and therefore, when we try to consider intervention, is really in refractory angina with or on medical therapy. And that medical therapy is important because we do see sometimes patients arrive on really very little medical therapy, perhaps aspirin, perhaps a beta blocker, sometimes not even a statin, sometimes not even. So it's interesting how it becomes hard then to make decisions because those decisions are hinged on the fact that they failed medical therapy. And so you may see in your referral back, so please optimize and up titrate, because some patients can do very well. So left main disease is clear in terms of what we offer. And this is where the sort of algorithm going down the line of multivessel disease, it's really important if we think the anatomy is suitable for intervention. And again, it doesn't necessarily mean that every patient with three vessel disease can be fixed by either PCI or CABG. So again, it's important for us to judge, and sometimes it becomes difficult in terms of the anatomy is diffuse disease that we don't believe that we can actually fix. And obviously the ejection fraction would favor revascularization versus the non. This is where the 2B indications were located for CABG and PCI. So again, it's sort of nuances a little bit our view of all of these things. And this is what we focus. It is worth stating that, the Canadian Cardiovascular Society and many of the societies were quite taken aback by the statement by the 2021 ACC and AHA, and actually most of these, and there are interventional cardiologists and clinical cardiologists on this panel for missing the goal, and that there was many editorial pointed out, and a lot of that data was based on the ischemia trial. And this slide is only to, not that I want to go into the details of the ischemia trial, but it points out, that the evidence of these prospective study, unfortunately, sort of tried to make things simplified in terms of good, bad, right, wrong, is revascularization good or bad? The problem was that these were not designed to test revascularization versus optimal medical therapy. This was around an aggressive investigative nature of angiography, and not all these patients obviously ended up. So it's a different question, but some conclusions were drawn from these questions. Not that the conclusions are necessarily wrong from the trial, but we should be careful in our interpretation of overall what they meant. So what does this mean? Does this mean that things are just more complicated? Just when you think that things can't get any worse, it starts to rain. Must have been in New Brunswick. So in my mind, it highlights the importance of three major things. Is again, the heart team as being important for us to decide and to discuss things. The importance of medical therapy is again there, and reevaluation, which is always complex or difficult in our current system, is as the end people that see, if I'm on call, you might do 10 to 20 angiograms a day. It's hard to imagine at the end of that you'd be able to reevaluate yourself all those patients. So we rely a lot on our referring doctors, because it would be impossible to continually reevaluate these patients ourselves. So we rely a lot on our referring physicians to reevaluate patients, optimize medical treatment, and reevaluate, and then make decisions along the way. So this is really important, how we rely on each other to do that. It also highlights in my mind that in reality, we focus on the end of the disease, where a small fraction only of the people we actually see. But in reality, there's this large bolus, as Brent alluded to, from a prevention point of view, or untreated, poorly treated heart disease out there that I still don't fully understand. How do we improve the health overall from a New Brunswick perspective point of view? So what are my take-home messages? Very similar to what Brent pointed out. Optimal medical therapy in stable ischemic disease is critical. There are complementary roles to PCI and CABG and revascularization, and this is why a heart team discussion is important to really get solutions. And these solutions are not always easy, and sometimes they're subtle. Like we would like for the outcomes to be hard outcomes in terms of survival advantage or benefit, but sometimes they're subtle around symptoms. And so this is when the risk-benefit balance becomes quite, you have someone in their late 70s or 80s in which you're trying to make a decision around symptoms when there's a risky intervention that may result in stroke or death. Well, that risk-benefit balance is very different than the 50-year-old or 40-year-old. There is some controversy around the new ACC and AHA guidelines, but that controversy is really not changed most of what we do. It's just enhanced, I would say, the way we need to discuss things and plan and review things in our mind. Thank you very much. And just a reminder, mini symposium on May 20th at the New Brunswick Heart Center. You're all invited. I will stop sharing and open it for question. Okay. So there's a few questions on the blog here. I don't know if David Marr, in our New Brunswick environment, for patients with symptoms of positive stress testing, would you recommend CT angio before referring to New Brunswick Heart Center for cardiac cath? As are there concerns around false positive, negative? Oh my God. I would say I would leave that to Brent on your analysis of.
And I just said it's really for the younger patients who have fewer comorbidities. If you have a 75-year-old diabetic smoker, a CT scan is going to show coronary calcification and likely coronary disease. It's not going to be that helpful because there is artifact, and we'll end up cathing them. At least that's been my anecdotal experience. But if you've got a 45-year-old with what seems like typical symptoms, but not a lot of risk factors, CT coronary angio may save them a cath and may clearly delineate either normal or really focal disease.
Also remember the ischemia trial was around 5,000 patients, and these were all moderate ischemia on functional testing as entry criteria with normal EF. So it does highlight, and half of those were treated as an invasive approach versus non-invasive approach.
Yes.
Anyways, just things to sort of imagine. Sometimes we focus a lot on the ischemia type imaging. I think it's important, not to say that it's not important, but it should not be the sole driver. There's another question here. For those who are younger, fewer risk factors, should have CT. Oh, you responded. Sorry, I didn't see that. Do the guidelines define refractory or failed medical therapy? Do you want to give a go at that, Brent? You've already responded.
The primary guideline document doesn't explicitly, at least that I could see or that I saw, define refractory angina. I mean, I think of it in terms of patients who have had an honest up titration of contemporary medical treatment, and in spite of that, they're having limiting quality of life impacting anginal symptoms. To me, that's refractory angina, but I didn't see an explicit definition in the guidelines.
Agree. If one last thing, if you were to comment on angina or anginal equivalent, we often say those things. And I'm referring mostly to, I guess, shortness of breath.
Yeah, so not an insignificant number of patients will experience dyspnea as their chest pain equivalent, so to speak. But the bulk of them are going to experience some form of discomfort in the chest. And I think if you press those patients with dyspnea, they'll often acknowledge, we all use chest pain as the descriptor, and patients will occasionally correct you and say, no, it doesn't hurt. It just feels weird, or it feels like this. So, I think there's probably another chunk of patients who would describe it differently if you ask the question differently. But certainly dyspnea is not an uncommon symptom as well.
Correct. From a cardiac surgical point of view, in general, angina, we can tend to do a very good job at improving that symptom. Dyspnea is a much harder one sometimes, because it's very hard to sometimes sort out other issues that will cause dyspnea.
100% agree. And I routinely tell people on the table that, you may feel less short of breath or you may not. And I explain the reasons for that. And I don't see them in follow-up, so I never know necessarily how accurate that is.
Yep. Okay. Any other questions from the audience?
Excellent review. It's Ron. Thanks to both of you. Quick question. With the new guidelines and the ambivalence, or the, I guess, controversy, are you now proposing revascularization for patients with multivessel disease only for symptoms, or are you proposing it for patients based on the older evidence you alluded to, if they have a low EF and proximal LAD or left main?
I think our practice has not changed tremendously, other than if you're a in stable patients, that there is room to increase medical therapy where symptoms are not that high. I'm much more inclined now to push them, unless obviously it's left main and that kind of stuff. I'm much more inclined to really see how they do for a period of time on medical therapy before jumping right away into an intervention. I mean, that's a little bit of my bias. Especially as they get older, because I'm not always sure that I'm really going to help them. And you really get a sense over several months whether they're getting better or not, or they're happy with their quality of life or not. I think it provides a little bit of safety from that point of view, because that trial was a 5-year trial. The ischemia gives you a little bit of idea on there is a bit of time to make that decision.
Agree.
Thanks for that. And I think you pointed out a lot of patients were excluded in that study. So we got to keep that in mind.
Absolutely. I think low EF patients, left main stenosis, remember the ischemia, there were, not all of them at 3 vessel coronary disease. So there's a lot of single and double vessel disease. So it is not, and that's why drawing full conclusions are difficult from that trial. And that was a lot of the dilemma with and the controversy comes from.
Thanks again.
Okay.
Jeff, quick question. It's Yemi.
Yeah.
So I think when you showed the diagram about the algorithm for patients with LV dysfunction, less than 35, with multivessel coronary disease, definitely if they are amenable to CABG, then that should be a consideration. But when they're not, suitable for CABG for whatever reason, it says an acts in discussion and to consider medical therapy or PCI. So with the new recent revived clinical trial, I don't know, has that changed your practice, Brent, in terms of multivessel disease, low EF, not amenable to CABG for PCI?
Oh, sorry, Yemi, were you asking me?
Yes.
Well, I guess it's mostly for PCI. I mean, the revive was about PCI in those patients. Being a negative trial, has that changed your practice?
I think we discussed those cases more, but I can't say it's. We probably still do intervention in those situations on occasion, but I think it has led us to reflect more, and often we'll review them with either one of us, or present some of those cases at heart rounds.
For us, there would be 2 reasons really in general that I find that you might not offer somebody surgery is if you feel that 1, the anatomy is not suitable, so you're not likely to help. And 2 is the comorbid burden is so high that your likelihood of benefit becomes unbalanced. So if if your risk of the surgery is more than 10 or 20% chance of dying at that day, so it's hard to offer something like that to somebody who's come as an outpatient from home. So that's where that dilemma comes.
And I think, I agree. I think from us, from an EP standpoint, I think my mind usually was, we try to push for revascularization. This patient coming in with new cardiomyopathy, low EF, before consider ICD. But the better medical therapy gets, and these evidence are coming out, sometimes I think we're a little bit less pushy for revascularization. And if EF is low after medical therapy, then consider them for different later. Anyway, thank you.
Thank you. All right, guys. Thank you very much for rounds. Excellent. Bye-bye.
Bye.